Hello, I'd like to get started. Welcome, everybody. Welcome to the next pre-holiday season installment of our Distinguished Visiting Scholars Public Lecture Series. It's great to see everybody out here again. I see a lot of familiar faces. I want to say at the outset, before I introduce today's speaker, I apologize for a little technical glitch. It had people running up and down stairs, but that probably contributes, as my wife suggested to me, to keeping people in good health and healthy aging, so you're welcome. Anyway, we're glad to have everybody here. Thanks for showing up. It is my distinct pleasure today to introduce today's guest speaker, Dr. Marie Bernard, who is the Deputy Director of the National Institute of Aging at the National Institutes of Health. Dr. Bernard started out her training as an undergraduate at Bryn Mawr College, where she studied chemistry. She then went on and did her medical degree at the University of Pennsylvania. And from there, she went on and stayed in Philadelphia, but went to Temple University to do her residency training. She did a fellowship through the Association of American Medical Colleges and their Health Services Research Institute that I found out was more or less a virtual type of a fellowship, wasn't actually located at the AAMC at that time, and was involved with the VA Faculty Leadership Program for end-of-life care through the Departments of Veterans Affairs. Dr. Bernard joined the faculty in internal medicine at Temple University after her residency, and then she moved to join the faculty at the University of Oklahoma Medical Center, where she was involved in a number of key leadership roles over the years while she was there. She served there as the director of their geriatrics program in the Department of Medicine. She served as the chief of staff at the O'Donoghue Rehabilitation Institute at the University of Oklahoma Medical Center, and director of the Oklahoma Geriatric Education Center. She then was a professor and chair of the Department of Geriatric Medicine, and then in 2008 she was tapped to join the National Institute of Aging, where she became the deputy director, where she is involved with the operations of that entire institute, including the co-management with the director of an over $1 billion, I think it's 1.2 or $1.3 billion annual funding to the NIA. Dr. Bernard has been recognized by her colleagues and peers in many ways for her multiple contributions to her understanding of aging and geriatrics and geriatric medicine. She received the Kent Award of the American Gerontological Society for exhibiting the highest standards of professional leadership in gerontology. She also received the Tibbetts Award of the Association of Gerontology in Higher Education, one of her passions of educating up-and-coming physicians and trainees and the importance of working together with older adults. And she's been recognized multiple times among the best doctors in America for her contributions in medicine. She's a fellow of the American Geriatric Society, and she has served on the editorial boards of numerous journals in geriatrics, including Geriatrics, the Journal of Gerontology, Geriatrics and Gerontology Education, and the Gerontologist. You know, after you say geriatrics and gerontology about 10 times, it's really hard, so I apologize. Her own personal research, as I said, has been multifaceted and multidisciplinary, tackling some of the most complex and important problems of the aging population. She has contributed to her understanding of better ways to address issues of nutrition and diet and vitamin supplementation in older populations, also dealing with management of medication and complex prescription regimes, not only for older adults in a home environment, but for those that end up in an institutional setting where the challenges can be greater. And again, as I mentioned earlier, one of her real passions is in education, including making sure medical students in training are exposed to older adults and understand the importance of appreciating the special needs of people throughout the aging process and how to deal effectively with them as patients, and also to try to dispel ageism in the entire community and medical profession. So as I said, she's taken on a whole host of major issues. From looking at the crowd, my guess is there's probably a lot of us in this room who are interested in what it takes to live to be 100 or maybe longer. And I'm just gonna ask the question, is anybody in the audience at 100 or close to 100 who would be willing to raise their hand and volunteer, hovering around that area? Okay, nobody's gonna fess up. Well, we're all on our way, one way or the other. So, without further ado, please join me in welcoming Dr. Marie Bernard.
Well, it's really a pleasure to be able to talk with you this evening. Yes, we all aspire to make it to age 100, and it's quite possible that a number of us will get there. And what I will do over the course of the next 45 to 50 minutes is give you some of the highlights of research from our institute, the National Institute on Aging. Our whole raison d'etre is to look at aging processes and try to facilitate the best quality of life and length of life possible for all of us. So I'll explore several areas, whether there are basic discoveries suggesting that life and health can be extended, whether we can manipulate environment and/or individuals to enhance health, whether we can slow down or prevent the dreaded Alzheimer's disease. When I was seeing patients on a daily basis, they'd always say to me, "Doc, I'd be perfectly happy to live a nice long life as long as I still have my faculties about me." And we all worry about that. And then I'll talk a bit about some research that's been supported by our institute, looking at limiting disability and offsetting some of the symptoms of illnesses of aging. I, as was mentioned, have a passion for teaching, and it's great to be back in an academic environment. So I'm going to start off with a quiz. Are you ready? All true, false. First, the longest that a human has been documented to live is 150 years. How many people think that's a true statement? How many people think that's a false statement? Okay. Longevity, length of life, is genetically determined. How many people think that's a true statement? And how many people think that's a false statement? Okay. Longevity can be manipulated with caloric restriction. We're not going to qualify it at this point. How many people think that's a true statement? How many people think it's a false statement? Okay. Longevity can be manipulated with medications. True? False? Okay. And I understand that many of you are faculty members, many of you have been to the basically mini medical schools that are offered by VTCRI, so I know I'm talking to a very sophisticated audience, but we're going to go through the data nonetheless. So this is a picture of Herman Epstein, age 100, who's at a senior living facility. He decided at 97 that he was likely going to make it to 100, and so he decided to start exercising at that point. And you see a picture of him with his physical therapist and with the group of folks at his senior center. He is not the longest living human. The longest documented human was 122, Marie Camon. Is it meant for us all to live that long? We don't know, but we certainly are interested in the factors that are associated with that. In fact, in Science magazine recently, there was a series of articles looking at issues related to aging. Scientists have been fascinated for quite a while at the variability that you can see. Anything from the fruit fly that lives just for a few days to the bowhead whale that lives hundreds of years. And it seems to be, at the animal level, perhaps related to weight, some exceptions being things like the naked mole rat and the little brown bat that apparently are good at eluding predators and live longer than you would expect for their size. We humans are in this place on this scale, but our scientists have been really fascinated with this for a long period of time and have tried and continue to try to sort out what accounts for various animals living their lifespan, us humans living the lifespan that we have. In fact, there's been a quest for a couple of decades into whether there are genes that regulate longevity. When you look at a particular species, for instance, clams, you can find clams that live as few as 10 years to as much as 400 years. So there's something that's going on there. And so they began to look at it in species like C. elegans, the worm. And this is a C. elegans at 3 days. Here's one at 10 days. Halfway through its lifespan, it's gotten wrinkled. It's not moving as quickly as the younger one, if we had this in video. And what they found is that manipulating the genes of the C. elegans made a difference in lifespan. The usual lifespan, about 28 days, could be expanded to as much as 175 days, depending upon what genes were manipulated. And in fact, as they looked at other animal species, mice, flies, yeast, similar sorts of things were found. There are a number of genes that seem to be associated with lifespan. They work in a variety of ways, but it seems that there may be some final common pathways for these, the inflammatory pathway, the mTOR pathway, that mediate the length of life for that animal species. So, does this apply to humans? Again, our scientists have been looking at this. This is a family group. We have a number of studies, something called the Long Life Family Study and others. This is a family group at the beginning of the 20th century, the same family group at the beginning of the 21st century. These people have been very generous in allowing us to follow them sequentially, do genetic testing, do other sorts of testing to try to figure out why they are living for a long period of time. And what has been found is that there are some genes in humans that are similar to the genes that you find in animal species, very specifically the FOXL3A gene, the ApoE2 gene, that seem to be associated with a longer life as well as better health. This is reportedly a 90 or 100-year-old gentleman who's doing a marathon. So there is a genetic component to longevity, it seems. What do we do if we aren't born with that? Our scientists are very interested in that as well. And so they've looked at ways that you can simulate the changes that are found genetically. And one of the first things that was found was that caloric restriction seemed to have a similar impact on longevity that some of the genes had. This is, and I need to be very clear, that's with regards to a specific strain of mice, because some more recent studies have suggested that it is strain specific. Some strains benefit from caloric restriction, some are harmed by caloric restriction, and some it makes no difference. But for this particular strain at least, caloric restriction starting after puberty led to greater lifespan, seemingly again working through the inflammatory or the mTOR pathways. This has already been translated into humans. We have a report that came out just last year of a study called CALORIE, Comprehensive Assessment of Long-Term Effects of Restricting Intake of Energy. It was a study that was designed to see whether you could get humans to adhere to significant caloric restriction. The goal was a 20% restriction. It focused, we're the Aging Institute, but aging is a lifelong process, so it was focusing on individuals who were 25 to 45 years of age. They were not really obese. They weren't terribly thin, but they weren't obese, with a body mass index of anything from 23 to approaching 28. And they were followed for a 2-year period of time. The goal was a 25% caloric reduction, and their energy, their cardiovascular risk factors, their endocrine response, and their immune function was monitored. And it was a successful study from the standpoint that they were able to get these people to stick to a caloric restriction. They didn't achieve the 25% goal. It was about a 12% caloric restriction, but their weight stayed down as a result of it for the whole 2-year period of time. And they were able to find that there were a number of parameters that changed in these individuals that would be suggestive that were carried on for a longer period of time, it could be beneficial. There was a decrease in thyroid function, still within normal limits, but decreased. It's similar to some of the changes that you'd see in animal models. There was improvement in cardiovascular markers, lipid markers. There were some changes that were of concern, some decrease in bone density that was out of proportion to the amount of weight that was lost. But it was a proof of principle that it is conceivable that one could do this sort of thing in humans. It took a lot of effort. These individuals worked with behavioral therapists throughout the 2-year period of time, and they clearly, obviously, were motivated to stick with this. But it opens up the opportunity for us to look at other things, whether it may be intermittent fasting or perhaps physical exercise that leads to a caloric deficit would bring about similar sorts of changes. For those of us who don't see themselves doing this sort of thing, our scientists continue to look. And one of the things that's been looked at is resveratrol. This is back in 2006 out of David Sinclair's lab. Resveratrol is found in red wine, and what you see here in black is the lifespan of a mouse on a normal lab diet. What you see here in red is the lifespan of a mouse on a high-fat diet, kind of the equivalent of a human's diet of eating a lot of McDonald's. And what you see here in blue is the lifespan of a mouse on the McDonald's diet and resveratrol. In fact, when this report came out in the mid-2000s, there was a lot of excitement because resveratrol is in red wine. You can just drink your red wine and eat your McDonald's and you'll live a long life. Challenge to this is that the human equivalent of the amount of resveratrol that was fed to these mice would be gallons of red wine per day, and that does have its health consequences. So our scientists continue to look at other substances that can be effective, and in fact, they found rapamycin, which is a drug that's used in individuals who are undergoing organ transplant, also extends lifespan, just as does resveratrol, caloric restriction. There are other drugs, metformin, acarbose, a number of things that are being looked at for the possibility of extending lifespan. They start in the animal models first and then potentially to test it in humans. There's a recent study that's a proof of principle of the potential for something like rapamycin to be effective. What was done here is that rapamycin in varying doses was given to humans over the course of 6 weeks. They had then a washout period, and the question was, would this have a beneficial impact in allowing people to take influenza vaccine? And in fact, it did. Of the 218 individuals who participated, there was a 20% overall increase in responsiveness to the vaccination. For those people who were really at risk, almost a twofold increase with really minor side effects. So again, a proof of principle study that you can potentially translate what's been going on in animals to humans. The research goes on because rapamycin is not without its consequences, and so the search is for drugs that work similarly to rapamycin. We're calling them rapalogs, to help with life and health extension. So, going back to the quiz, the longest that a human has been documented to live is not 150 years. Longevity is probably genetically determined for the lower animals. For us humans, there are other factors that play a role as well, which I'll get into very shortly, but there is some component of that for us as well. Certainly it appears that longevity can be manipulated with caloric restriction in certain strains of mice. And we have the study that shows that humans can, for a period of time, adhere to caloric restriction. Whether in the long term that's going to be a beneficial thing, the jury is definitely out on that. It's going to be a long-term follow-up. And certainly, again, in animal models, longevity can be manipulated with medications. Whether that will end up being applicable to humans, we continue to look at and are actively supporting that sort of research. So, I said that it's more than genes for humans, that there are other factors, and part of those other factors are our behavior. So, I hope I've modified your behavior. You ready for the next quiz? Okay. Okay. So, health insurance can lead to improved health parameters. True or false? True? Okay. False? Okay. How many think that physicians can have their behavior modified? True? False? True. Incentives can induce better compliance with desired health behaviors. True? False? Okay. Mortality rates in the United States are declining. True? False? Okay. So let's examine the data. This is the report of a study that was supported by our institute. We're interested, as I said, in the lifespan and all the factors that affect health and lifespan. And these are researchers who took advantage of a natural experiment that occurred in the state of Oregon at the beginning of this century. Oregon found itself in the position that they didn't have enough money to cover all the people who might be Medicaid eligible. And so they got a special waiver from the Centers for Medicare and Medicaid Services to conduct a lottery. And so they opened it up to all those people who were eligible and randomly picked some 10,000 out of the 70,000 people who were eligible for Medicaid and put them on the insurance. And then our researchers looked at outcomes of these individuals a couple of years after they'd had the insurance. The control group were those who didn't get the insurance, the Medicaid group here. And what they found is that definitely there were benefits to this modification, this manipulation of their environment. There's more in the way of cholesterol screening, more in the way of having a usual place of care, less in the way of depressive symptoms, more in the way of use of diabetic medications, because presumably they were seeing the healthcare provider on a regular basis, and very nice also additional benefit, there was less borrowing money or skipping bill payments because they did have regular insurance. So definitely some beneficial health outcomes as a result of that sort of manipulation, environmental and manipulation, you might say. Can you modify a physician's behavior? Actually, you can, even though sometimes I wondered when I was a department chairman. This is a report by Meeker and colleagues that came in the Journal of the American Medical Association last year that looked at what you could do to get physicians not to inappropriately prescribe antibiotics. I think we've all heard about the problem with all these superbugs that are around because antibiotics are being given out inappropriately to humans as well as animals. And in order to decrease those sorts of problems, you want to make sure that you're giving antibiotics when there's truly a bacterial infection there and not just for the flu or for a virus. So what happened in this study is they got a commitment from physicians in various clinics to either be in the control group or to make a pledge that they were not going to inappropriately prescribe antibiotics. And that pledge was listed as a poster in the exam room. And what they found at baseline is that the inappropriate prescribing was approximately equivalent. But after the intervention, that inappropriate prescribing went down for those practices where the poster was displayed, as opposed to going up actually a bit in the other practices. I think that this is a great example of something that can be done at very little cost. And in actuality, it's really kind of modifying the behavior of the physician as well as the patient, because many a time a patient will come in and say, well, doc, I've got to have something. And having that sort of pledge that's posted there helps both in terms of that negotiation. So what are some of the things that we can do very specifically for patients or for people beyond docs? Well, there's this recent report by Ash and colleagues in the Journal of the American Medical Association. Again, all of this is research supported by our institute, looking at incentives to reduce lipid levels. High cholesterol is a very common problem in the United States, and data suggests, depending upon which data you look at, as many as 20% or more of individuals who ought to have their cholesterol under control or be on medications are not getting medications for that. And so what they looked at here was bringing the LDL cholesterol, LDL is the bad cholesterol, level down. The control is in the white circles. What you see in orange here is giving incentives to patients. What you see in the square is giving incentives to physicians. And what you see in blue is a shared incentive for both physicians and patients. And as is hopefully evident, the shared incentives, very clearly stated, shared incentives, were much more effective than the control or any of the other interventions, bringing the cholesterol level down from 160 to a little bit more than 120. So again, there are things that you can do to manipulate the environment, to change behaviors, to change the way that you're approaching things. This is now looking very specifically at individuals outside of the healthcare setting, and that's the behavior of smoking. I spoke to one of your really esteemed researchers, and this is also something that's funded from the Science of Behavior Change Initiative at the National Institutes of Health, led this particular project by our staff at the National Institute on Aging. So Kevin Volp, Scott Halpern, and colleagues wanted to figure out what's the best way to motivate people to give up this very addictive behavior. So they worked with CVS Caremark and took advantage of all of their employees, their friends and family as potential subjects, and randomly assigned people to either get an individual reward or to get a group reward, presuming everybody in the group is doing well, or to put down money of their own, $150 in order to get $650 back, so a total of $800, or to be in a competitive deposit. You put your money in and then you get your money back if you abstain, and you get even more if other people in your group don't abstain. So people were randomly assigned to one of these 4 groups, and as you can see, very few people really wanted to put their own money into this. Many more people were very willing to get $800 for abstaining, but didn't want to put $150 in order to get that money back. What was found is that regardless of the intervention, this sort of reward or deposit approach was more effective than the control conditions in getting people to stop smoking at 6 months and even at 12 months. Of course, there's going to be recidivism, but each of these were very effective. What the authors also found is that when you look in proportion to the individuals who went for the deposit approach, they are more successful proportionately than the people who had the individual reward approach, suggesting that if you have a little bit of skin in the game, or if you have a carrot and a stick, it's going to be more effective in bringing about modification in behavior. And this becomes very, very important when you think of things like what's going on with mortality in the United States. This is a report from Angus Deaton, who is this year's Nobel laureate in economics and one of our grantees, we're very happy to say. They were looking at, he and his group were looking at morbidity and mortality in the United States and across the globe. And what you see here are mortality rates for people in France, Germany, US Hispanics, people in the United Kingdom, Canada, Australia, Sweden. Mortality rates are going down from 1990 through to 2010. This in red here, however, represents the U.S. white population. It was going down from 1990 to 2000 and has been going up from 2000 through to 2010. This was of great concern. It showed a reversal of decades of progress in mortality. Generally, we've had a downward trend even before the 1990 data that are shown there. It, as you can see, was unique to the United States. And as they further untied it, it was unique to white non-Hispanics who were 45 to 54 years of age. Why? It's largely due to increasing death rates from drug and alcohol poisonings, suicides, and chronic liver disease, generally alcoholic liver disease, all illnesses that are behaviorally based and potentially could be modified. They found that it's also associated with the educational level, with those with the least education showing the greatest increases. So these are very important issues if people are going to have longevity and a good health span, and we continue to support research to try to help with that. So going back to the quiz, health insurance can lead to improved health parameters. Yes, that's true. Physician behavior surprisingly can be modified in spite of some resistance at times when you're a department chair. Incentives can induce better compliance with desired health outcomes, and mortality rates in the United States are not declining in all groups, and that's of great concern. So, transitioning on to that issue of cognition and Alzheimer's disease. Again, many a person would rather have a short life and good cognition than a long life and dealing with dementia. And we at the National Institute on Aging are designated as the lead research entity at NIH in Alzheimer's disease. So I'll talk a lot about that. But of course, we have to have a quiz. So you ready? Okay. Alzheimer's disease is more costly than other common causes of death in the United States. True? All those? False? Okay. There is a national plan to slow or prevent Alzheimer's disease by 2025. True? False? Okay. Biomarkers, scans, blood tests, spinal fluid tests can show signs of Alzheimer's disease decades before clinical presentation. True? False? Okay. Cognitive and physical exercise clearly slow or prevent Alzheimer's disease. True? False? Okay, let's dive in. So this is an important problem. I think we're all very aware that it's common. Everyone probably knows someone or has a relative who's had Alzheimer's disease. Currently, it's estimated that as many as 5.1 million people in the United States have Alzheimer's, and it's projected that by 2040, that figure will go up to about 14 million. It's a disease of aging, and with us baby boomers aging, there are going to be a lot more of us around and a lot more likelihood that people will have Alzheimer's disease. It is costly. This is a report by Hurd and colleagues based on our health and retirement study. The health and retirement study is a national probability sample of individuals 50 to 79 years of age looking at that retirement transition. And they used data from that and then extrapolated it to the country as a whole to get the first really good estimates of the costs of Alzheimer's, of dementia, they say, the most common dementia being Alzheimer's. And they found that in 2010, the direct cost of Alzheimer's was probably about $110 billion. That's the cost of hospitalizations, nursing home stays, medications, et cetera. But when you take into consideration the cost of informal care, whether that's care that's given by family and friends and the foregone wages, or the cost to get professionals to take the place of the family and friends, the total cost of Alzheimer's was more like $150 to $210 billion. And then projecting through to 2040, without even taking into consideration inflation, just considering the increased population likely to have Alzheimer's disease, they project that the cost of Alzheimer's will be about $250 billion in 2040. That's direct cost. And when you take into consideration the total cost, it'll be anything from $375 to $510 billion. So very costly. As compared to the cost of other illnesses, Amy Kelly and colleagues did a very nice analysis, again from the Health and Retirement Study data, looking at the cost of care in the last 5 years of life. And what they found is that whether you were looking at total cost, and this is Alzheimer's or dementias, again, most commonly Alzheimer's dementia, versus cardiovascular disease, cancer, and other causes of death, that the total cost was higher for dementias. Medicare and Medicaid costs were higher. Informal care costs and out-of-pocket costs were higher. So it's a very costly illness in terms of emotional suffering, taking your loved one away, making it so that you're not able to work as you otherwise would, and in actual dollars. And yes, there is a national plan for Alzheimer's disease. President Obama in 2011 signed into law something called the National Alzheimer's Project Act, which called for us to develop a plan. In 2012, the Secretary of Health and Human Services delivered that plan as stipulated by the law. It has 5 goals. And the research goal is to find prevention or a cure by 2025. Now, I will tell you that makes our scientists very nervous because you can't guarantee that you're going to find something in a particular time frame, but we're certainly giving it a try. And I think as a geriatrician that we are better positioned than ever to try to meet that goal. What are some of the things that are going on? Well, for the last more than 20 years, we've been looking at what's going on genetically with Alzheimer's disease. At the beginning of the 90s, we knew that there were 4 genes associated with this. The ApoE4 gene that's associated with late onset Alzheimer's disease, and the amyloid precursor protein presenilin 1 and presenilin 2 mutations that were associated with early onset Alzheimer's disease, relatively rare forms of it. Then we had a drought in discovery from 95 to about 2009 as genetic techniques were being further refined. And starting in 2009, there was a real explosion in discovery to the degree that we now have some 22 Alzheimer's disease loci identified. And as we better understand the pathways by which these genes work, the potential to identify targets for treatments and for preventive therapies. Similarly, we have had quite a bit of advancement in bioimaging to allow one to see what changes are occurring in the brain of people who may develop or who have developed Alzheimer's disease. This is an example of MRI scans that have been done on subjects in the Baltimore Longitudinal Study on Aging. This is a study that's supported by our institute. It's actually been around since before our institute. It's been around for more than 50 years. It's a study that takes people 20, 30, 40, 50 years of age and follows them for their life. And they come in every year or two and get very extensively evaluated with laboratory tests, physical tests, et cetera. And they now have a sufficient number of people who participated in this study who have developed Alzheimer's disease to allow comparison of some of the scanning to things that occurred many years before they developed Alzheimer's disease. And it's allowing our scientists to try to figure out what among the things that have been tracked might be able to predict that a person was going to develop this illness. Similarly, in the extramural world, there's quite a bit that's going on. We're able to look in the brains and see the accumulation of amyloid within the brain, the amyloid plaques that are characteristic of this illness. We're now even able to look at what's called tau deposits, the tangles that are associated with this illness. Now, 20 years ago, you had to wait for a person to die and do an autopsy in order to see those things. Now we have scanning that in the research setting seems to be suggestive that those changes are there. So that you will have in a person with Alzheimer's disease changes such as this. The big challenge is that you will have some people who are cognitively normal who have changes that look like they have Alzheimer's disease. And so the question is, are these people going to eventually develop Alzheimer's disease? Are these people resistant to these changes? And the research goes on. We also have intervention studies, and I'm only giving you an example of the many that are ongoing. This is a study led by Eric Ryman and colleagues at the Banner Health Institute in Arizona. They have a relationship with a family in Colombia that has a presenilin 1 mutation. That's the one that one of the three that causes early onset Alzheimer's disease. These are people who in their 20s will have pretty normal looking scans like this. In their 30s, if they don't have the gene, they'll have scans that look like this. But in their 30s, if they do have the gene, they'll have changes like this. And by their 40s, they will have the dementia. So in this study, a drug is being administered to help remove amyloid from the brain with the hope that that intervention will slow or prevent the development of the illness. And the thing that's really neat about the study from my perspective is that it's what's called an adaptive design. If in giving the drug they don't find the progress that they expect, they will potentially switch over to another drug to see what could happen. So we're very grateful to volunteers such as these who help science to advance in this fashion. There are studies looking at people with late onset disease, people with ApoE4 abnormalities, people with Down syndrome. People with Down syndrome tend to have Alzheimer's disease in their late years as well. A lot that's going on that will hopefully help us to get a better handle on this illness. In fact, we are not the only entity that's looking at this. Francis Collins, the NIH director, has brought together a group called AMP, Accelerating Medicines Partnership, that's looking at Alzheimer's disease, rheumatoid arthritis, and type 2 diabetes. Dr. Collins' vision was that we needed to develop some effective new medicines. Generally, it takes too long, costs too much, and medicines fail too much. There's this valley of death between the development by NIH and other basic entities and pharmaceutical companies. And this partnership brings pharma, private foundations, and government together in that pre-competitive space to try to find ways of accelerating discovery. From the Alzheimer's perspective, there are a number of industry partners, government partners, including the FDA and the Neuroscience Institute, as well as the National Institute on Aging, private partners, with total funding contributing an additional almost $100 million to the Alzheimer's effort. This is allowing us to add tau scanning to a number of the intervention studies that we're currently supporting. What can we do in the interim while we're waiting for this cure or prevention? Well, there are a number of suggestive studies, such as this report from Reebok and colleagues, follow-up data from intervention called ACTIVE, Advanced Cognitive Training for Independent and Vital Elderly. In the ACTIVE study, they took older adults and put them through training in various cognitive domains. This shows training in reasoning. And as a result of several weeks of training, 2 or 3 times a week, their reasoning scores went up, as you would expect. The thing that's impressive to me about this is that the reasoning scores stayed up over the course of 10 years of follow-up. A small number of people got some booster training, but the majority did not. So reasoning was better as a result of an intervention 10 years earlier that was just for a few weeks. Similarly, when it came to speed of processing, and speed of processing of data is something that definitely decreases with age. You hit your peak at about age 30, and it's downhill from there. Unfortunately, there are a lot of things like that. What they found in this study, however, is that you did the training, and the speed of processing benefits were also seen 10 years later. They did a similar thing with memory. The memory benefits only lasted for about 5 years as opposed to 10 years, but still pretty impressive for something that's a few weeks worth of investment of time. And what they found is that there was some crossover of this, that the speed processing, memory, and even memory and speed processing and even reasoning, all of them were better than the controls at 10 years. So there was some crossover there. In instrumental activities of daily living, instrumental activities of daily living being things like managing medications, doing banking, things of that sort. So you would expect that if you're better at speed of processing and reasoning, that you might be better in those sorts of domains. And it's encouraging. It's not definitive. So before I get to the next slide, how many people do Angry Birds? Okay. And how about Super Mario Brothers? Okay. I saw somebody all the way back. And I guess true or false, does that have cognitive benefit for you? Well, certainly there's a report that just came out yesterday from Clemenson and Stark that looked at virtual environmental enrichment through video games. And they looked at people who did not do gaming versus having them to do Angry Birds versus having them do Super Mario Brothers 3D World. And what they found is that the people who did the Super Mario Brothers 3D World had seemingly enhancement of hippocampal function. And the hippocampus is the area that tends to deteriorate earliest when one's developing Alzheimer's disease, suggesting that there could be some benefit to this sort of intervention. Again, it's only suggestion, it's not definitive, but intriguing, and I see a lot of people smiling out there. So yes, you can keep doing your games right now. I will, again, though, caution that we don't know that this is the silver bullet to help against this illness. In fact, in 2010, NIH sponsored what's called a State of the Science conference to see where we stood in terms of preventing Alzheimer's disease and cognitive decline. It was a study where the Agency for Health Research and Quality looked at all of the literature, all the studies that had been done up to that time to see where things stood. And then an expert panel looked at those data and came back to us with recommendations. There's charge being, is there sufficient data to say that we need to have some public health recommendations about how you prevent this illness, Alzheimer's disease and cognitive decline? And at that point, they did not feel that the strength of the evidence was there for us to make such definitive statements. You see that I've shared with you a couple of studies that are suggestive that there are things that can have an impact upon cognitive decline. And thus, we at NIA are again supporting a study to look at that. This time, it's done through the National Academies of Science, Engineering, and Medicine, their Institute of Medicine. And the first meeting will, in fact, be next week, December 15th, 16th. You can go to the National Academy's website to find out more about this. It is an open public meeting, so you can go in person, you can participate by webinar. And they will take a look at it again. The Agency of Health Research and Quality is going to do, again, a very comprehensive review of the literature to see what's happened since the last study. And then an IOM panel this time is going to look at those data and help us to understand whether we're yet at the point that we can say, yes, you should go do Super Mario Brothers, or yes, you should go buy such and such a game. So it'll take a good year to a year and a half for this to be completed, but it should be very helpful in thinking about this. So let's go back to our quiz. Alzheimer's disease is more costly than other common causes of death in the United States. Certainly, Amy Kelly's study suggests that that's the case. And yes, there is a national plan to slow or prevent Alzheimer's disease, and lots of us hope that we'll be able to meet that goal. Yes, there are biomarkers that can show signs of Alzheimer's disease decades before clinical presentation. They're useful in the research setting. They're not yet useful in the clinical setting. There's a lot more validation that needs to occur. And no, we do not know definitively that cognitive and physical exercise can slow or prevent Alzheimer's disease, but we're going to continue looking at that, and our researchers are going to continue working to try to get that definitive answer for us. Okay, so last set of questions. This first one, if you're a woman who's, I'm not going to tell you my age, but if you look like you're around my age or older, let the other folks answer. True or false? Women may suffer from menopausal vasomotor instability, in other words, hot flashes, for as many as 10 years. True? I heard a lot of women responding there. False? Okay. Next question, and this time, gentlemen, let the women answer, okay? Testosterone supplementation is helpful for low vitality in older men. True or false? True? Okay. Next question. Metformin is as effective as exercising in preventing diabetes in the elderly. True? How many hands? False? How many hands? Okay. And then finally, it's been demonstrated that exercise can prevent the development of disability. True? False? Okay, so let's look at the data. So this is a study by Avis and colleagues in the JAMA Internal Medicine this year, and it's looking at all women with, at baseline, they've started off with hot flashes from our study of women across the nation. And it looks at what happens over the course of time, and this scale down here is years. So you see the scale goes out to 14. This here is the median, or the halfway point, where half the women have stopped having flashes and half still continue to have flashes. And what you see here is that it ranges from 4.8 years at median for Japanese women to as much as 10.1 years for African American women. It's a problem, as was demonstrated by the responses to people on the exam that I gave just before. What can we do about it? Jaffe and colleagues in JAMA Internal Medicine last year reported from our MS Flash menopausal strategies for lasting answers and for symptoms and health. Looked at venlafaxine, which is an antidepressant in SSRI, and found that it was almost as effective as estrogen in helping with hot flashes. It was definitely more effective than placebo. And this is good news, I think. There have been a lot of concerns about the health effects of estrogen. Venlafaxine is a drug that's been around for quite a while. We know its side effect profile. The one limitation of this is that this is a study that was done for only 8 weeks. And when the medication was stopped, the frequency of flashes and the severity of flashes returned to the prior baseline. So what's really needed is further follow-up data to see whether the benefits can persist. But some hope beyond home remedies or taking estrogen. So the question that was for the men, we have a trial called the T trial, the testosterone trial, that has been completed. The data have been crunched, and there is a paper that's soon to be published. It's currently embargoed, so I'm not going to be able to tell you answers here. But it's a study that looked at men who were 65 years of age and older who had a biochemically demonstrated low testosterone level, none of the reported low T that you used to see in commercials. And in addition, they had either difficulty with walking a quarter of a mile, or questionnaire demonstrated decrease in sexual drive or decrease in vitality. And they were randomly assigned to get either a testosterone gel or a placebo gel. The domains that were looked at were physical function, sexual function, vitality, cognitive function, anemia, cardiovascular status, and bone health. And we expect any time now that the paper will be released, so I would encourage you to keep an eye out for that. Diabetes and metformin was another question that we had, and these are data from the diabetes prevention trial that was completed more than 10 years ago. Our institute joined the Diabetes Institute to try to make sure that there were older adults included in this. It was a trial that looked at cumulative incidence of diabetes in people who were at risk and compared lifestyle interventions, exercise and weight loss, versus metformin versus a placebo. And as you can see here, there are definitely differential effects. For the younger population, lifestyle and metformin were approximately equivalent in efficacy. For middle-aged individuals, lifestyle and metformin were both more effective than placebo, although the metformin was perhaps not quite as effective as lifestyle modification. But for individuals who are 60 and older, lifestyle modification was significantly more effective than it was for the younger populations, and more so than metformin. Metformin was approaching the effectiveness of placebo. So I think it was a really good thing that we were able to join NIDDK in this study and make sure that there were older adults in good numbers included, because you would not necessarily have been able to tease out these data otherwise. The other part of this that's quite impressive to me is that at 10-year follow-up, as reported in 2009, the people with lifestyle modification continued to have less in the way of accumulation of diabetes than those people on metformin or placebo. Again, the intervention stopped 10 years before, but there was a residual benefit of having been in the lifestyle modification group. This has led to lots of different efforts to make sure that people exercise. We at the National Institute on Aging have a program called Go for Life. If you're interested in it, you go to nia.nih.gov. It's a wonderful free online resource that can help older adults who've not been active think about how to go about doing that and how to do it safely. You can join an online community to interact over it. It's an important thing, as you can see, if you're at risk for diabetes. We took our interest in exercise and its impact on aging a step further in a study called LIFE, Lifestyle Interventions and Independence for Elders. This was a study that was designed to ask the question whether you can prevent major mobility disability. We knew that you can prevent diabetes. We showed that in the diabetes prevention program. We knew that you can decrease cardiovascular risk factors as a result of exercise, but it was not definitively known whether you can prevent disability. And in fact, some people would argue that somewhat frail older individuals who were the subjects of this study are somewhat at risk of having a hip fracture or a knee problem as a result of exercising. So this is a multi-center randomized controlled trial of some 1,600 non-disabled community dwelling individuals, but people with functional problems. They were put through what's called a short physical performance battery, and they functionally had deficits, but they weren't truly disabled, and they were 70 to 89 years of age at baseline. And what was found was that walking, resistance, balance, and stretching combined decreased the likelihood of disability by 18% for those people who got that intervention versus the controls who simply had a healthy aging education. The length that, if they were to become disabled, the length of time that they were disabled was less than that for those people who were in the control group. So again, exercise seems to have a role here. And Our commitment to that has been, for the White House Conference on Aging, we sponsored what was called Go for Life Month this past September, and we anticipate we'll probably do that on an annual basis. So again, nia.nih.gov to find out more about Go for Life. So going back to the quiz, yes, women unfortunately may suffer from hot flashes for as many as 10 years or beyond. And I can't tell you about the testosterone trial, but keep your eye out for it. Metformin is not as effective as exercise in preventing diabetes for the elderly. And exercise seems to be an important thing to prevent the development of disability. So in closing, can we truly live to 100? For many of us, that may be the case, and our job at the National Institute on Aging is to enhance your health span as well as your lifespan. So I would hope that you take away from what I've said today is that there are some promising interventions developing for extension of health and life, that there are manipulations that can be made at the individual and societal level that can enhance health, and our scientists continue to look at other things that can be helpful. Again, I really think that if ever we were going to be in a position to find a prevention or a cure for Alzheimer's disease, we're positioned to try to do that, but we'll have to see how the science evolves. And exercise may limit disability and offset some of the symptoms and illnesses of aging. If you want to find a fountain of youth, maybe exercise is that. So I really thank you for the opportunity to talk with you today. It would be, I guess, happy to answer questions, huh? Okay.